Hey everyone, this is Dr. Zach Ruin here, Performance Sport and Spine. In today's video, we're going to go over lumbar stenosis. This can be an incredibly frustrating and scary condition, so our hope is by the end of this video, you have a better understanding of the condition, ways that you can manage it yourself, and then when imaging and surgery are applicable. So lumbar stenosis is a narrowing of the spinal canal with back pain, and it also may associate with neurogenic claudication, which is basically leg symptoms, which we'll discuss later in detail. So lumbar stenosis can have several different kinds of causes, and they're kind of grouped into two subgroups. The first one being congenital or primary, which is basically you're born with it, and then the second is acquired. So there could be degenerative changes or infections or post-traumatic changes that happen to your spine. We'll be addressing degenerative lumbar stenosis as that's the most common subgroup, and it's important to note that there's changes to your bones, your discs, and your ligaments with this condition. So how do you know if you have lumbar stenosis? Well, it's based on a good history and physical exam that can be augmented with radiographic imaging. Now, it's important to note the most decisive factors are a history and exam. You can't tell if someone has stenosis just from an image. So here are 5 cardinal criteria for lumbar stenosis. The first one is the exertion test. So getting up and walking around. If you have pain in the legs in less than 30 seconds, that increases the likelihood. The second being, are you over the age of 60? And the third is, if you sit down, does this relieve your symptoms in your legs? Fourth would be, are your symptoms bilateral? Are you experiencing pain or symptom in both legs, not just one? And then lastly is a negative straight leg raise, which is an orthopedic test to put tension on the sciatic nerve. Again, if this is negative, it increases the chance that you have stenosis. So not all lumbar stenosis cases will be the same, and they can be broken down into 3 subgroups depending on symptoms and radiographic findings. So there's mild, moderate, and severe. For almost all mild to moderate cases, they can be handled and managed conservatively, where severe cases may indicate surgical intervention. It's also important to note that the onset is very gradual usually, and that people may report having symptoms feeling of heavy legs. Have you ever noticed when you're at the mall or a grocery store by bending over and pushing your shopping cart that helps alleviate some of your leg symptoms? This is called the shopping cart sign and is indicative of stenosis. So with stenosis, arching the back or extending it narrows the spinal canal and makes it worse, whereas sitting or flexing the spine and rounding your back increases the distance and helps the symptoms. So postural modifications is a huge part of a treatment plan. So for standing postures, try to sit more and stand less. But when you do have to stand, a couple helpful cues are, if you find when you're standing that your weight's more on your toes and you feel like your shoulders are behind your hips and your back's kind of arched, this will narrow the spinal canal and put more tension on the nerve. So kind of pulling your pelvis back so your weight's more on your midfoot or your heels can help, as well as kind of letting your shoulders relax or pulling your ribs down towards your spine, which helps decrease the lordosis of the back and can open up the canal. So walking is kind of an extension-based exercise. So a couple of things that you can work on is when you're walking, really try to kind of slouch forward or let your back relax. And again, try to keep your weight over your midfoot and pull those ribs in, and sometimes increasing or decreasing your stride rate will also help. But again, you got to figure out ways to decrease that irritation for this condition to calm down. Also with walking uphill is preferred to walking downhill, because when you walk uphill, you naturally have to lean forward, which flexes the lumbar spine, which increases the spinal canal. On the converse, walking downhill makes you arch backwards, which decreases. So if you have the option, try to walk uphill more. And also another great exercise is cycling, as it puts you in a slouch position, which will alleviate your symptoms. So sitting is very helpful for this. So again, there's a couple things that we can do. We can adjust the chair or the height of the chair to your symptoms, but again, let your symptoms dictate what chair you use, not your perception of right. And then lastly, if you have any sort of lordosis or spine support, get rid of it, because again, the more your back is arched, or the more it's extended, it's going to decrease that canal and increase your symptoms. So often with this condition, the lower the chair, the lower the step, the more the back is rounded or flexed, which increases the distance of that canal, which is often more comfortable. So you may want to try and decrease the chair height or find a lower step, such as what we show here, and try to see if that feels better. So the last postural modification is when you're standing doing household chores such as cooking, or maybe you're at the gym wanting to work out, finding a small bench and then placing one leg up on it, helping the back relax and decreasing that extension can help decrease your symptoms and let you do the activity for longer. And you may want to switch every so often to help add some movement, but finding a bench with different heights may be a great kind of short-term hack. So now we'll go over the stretches and exercises portion. And again, it's important to try to keep the spine out of the extension or arch position and in neutral or somewhat slouched or flexed. So the first one, sit on a bench with your legs straight and then reach down with your arm to the opposite leg. Now reach down to tolerance, and a couple things to note is don't hold your breath and don't guard your spine. So you don't want to keep the muscles in your back tight. You want to just reach down and let things be as relaxed as possible. So posterior pelvic tilt. So think of your pelvis as a cup. You want to pour the water out the back. So a couple helpful cues are pulling your belly button to your belt buckle, or squeezing your abs and your glutes to rotate your pelvis or your brim of your butt backwards, and your back should flatten against the floor. So the quadruped rock back. On your hands and knees, just gently rock back onto your heels, letting your back round and relax your back. Again, try to go down to tolerance, and you don't want to hold your breath or keep your back arched. If you do this, it'll hurt, so just keep your back relaxed and press backwards. So just a standing march can be effective. So just taking one leg and bringing your knee up as high as you can help, because as you bring your knee up, it helps kind of bend or relax your spine. And again, try to keep your shoulders forward and minimize any extension. So the kneeling reach out. On your knees, kind of reach out and rock your heels back. Again, stand up and again, rock back, reach out, not holding your breath, letting your low back relax as much as possible. So just laying on your back, just bringing your knees to your chest can be a good stretch and exercise. And again, keep your back kind of gently pressed against the ground and then pull your knees up to tolerance with your hands. So supine crunch, so laying on your back with your knees bent, with your hands behind your head, just using your abs, lift your head and upper body up towards the ceiling and then down to tolerance, trying to keep your back flat and not using your neck muscles, but using your ab muscles. Banded bent over row, so bending over with the band anchored close to the floor with one hand on your knee and your back kind of bent and relaxed. Just kind of pull the band to your arm to tolerance, make sure to keep that slouch position and then increase the distance or the band as you get stronger. And initially, any of these exercises that we show here that are kind of extension or arch based should be avoided, as they'll just exacerbate your symptoms and make the pain worse. Now in time you may be able to get back to them, but it will be different for each person and it's better to go slow than fast. So the conservative care should be to reduce pain and improve physical function, and this would be most applicable for mild to moderate cases. So the goals are rehabilitation with a flexion bias, some manual therapy may be warranted, neuromobilizations and delordotic devices. Bed rest is not recommended, so please don't lay in bed. This won't fix it. Rest does not fix this condition. And then lastly, patient education. So understanding what's going on and how best to manage this is extremely important for successful outcomes. So there are different classifications of spinal stenosis. So there's central stenosis, that's where the spinal cord is getting pressed by the middle of the spinal canal. There's lateral stenosis, that usually affects only one side. Or there's foraminal stenosis that affects the nerve root as it exits the spinal column. And it can also be single segment or multi-segment. And there's different grades, 1, 2, or 3, mild, moderate to severe. And the most common level is the L4, L5 DIS level. So differential diagnosis, there's some other conditions that we have to make sure that we've ruled out. So the first being intermittent claudication or vascular claudication. So this will be a decreased or absent peripheral artery pulse, and it's better with rest, usually within 5 minutes standing or sitting. And most importantly, riding a stationary bike will exacerbate this condition because it's a vascular issue, not a nerve issue. Radicular pain or radiculopathy. Typically this has a positive SLR test. It's more dermatonal. There may be neural deficits or motor weakness. There's leg pain is worse than back pain, and it's usually only one leg that's affected, and sitting or bending forward makes it worse. So the iliac joint can also refer pain somewhat similarly, but this again can be ruled out with functional or physical findings and then positive orthopedic test. So peripheral neuropathy, this could be ruled out with EMG test. And then inflammatory issues. Now these would be probably more systemic in nature. There'd be positive inflammatory blood markers if blood work was done, and there'd be imaging findings that indicate this is the case. So now we'll discuss imaging and the role it plays. So first, conventional x-rays do have some utility for ruling out fractures, infections, or alignment issues. Functional myopathy is best for functional posture assessment. MRI is usually the preferred choice. Typically, it's only needed for moderate to severe cases. And again, the radiographic or imaging findings have to collaborate with the clinical findings and assessment. And then also it can be used for pre-surgical patients. So when you talk about how sometimes imaging findings can be seen on people that are asymptomatic or pain-free. So this study found that 20% of people over the age of 60 had radiographic or imaging findings of lumbar stenosis, but they had no clinical sign and symptoms. So I implore you, don't let anyone base your diagnosis strictly off just an image. So the prognosis for the condition is a little bit spotty, but there is good resolution for most people for mild to moderate symptoms with conservative care. Now this study did find that 70% of people plateaued, 15% got worse, and 15% got better. But it's important to note that an acute flare-up of pain does not necessarily mean that condition is worsening. So if you do something over the weekend that's way out of the ordinary and your pain flares up, don't get too alarmed. Give it a few days, and if it calms down, it's just a normal process of the fluctuating symptoms, and you're not making the degenerative process worse. Okay, so injections will provide short to middle term relief, but they should only be used in conjunction with other rehab and physical activity, and they're probably more effective short term than long term. So if you had lumbar stenosis for a month or two, they're probably going to provide some relief. If you've had it for 4 years, it's probably not going to do much, and there's better options available. So the surgical aim is to decompress any entrapped neural components. The success rates vary from anywhere from 60–90% based on a bunch of different factors. And it's probably warranted for people that have severe pain, such as someone that can't do what they do, they can't get dressed, they can't take care of their kids. If their pain's so bad, it probably indicates that surgically at least should be an option, as well as cauda equina, which is a compression of the nerves leading to bowel and bladder changes, or progressive or sudden muscle weakness. So there are complications with any kind of surgery, and these range anywhere from 14 to 35%. Some prognostic factors for successful outcomes are young age, short preoperative claudication duration, symptom relief with flex positions, and then limited comorbidities. One thing interesting is for degenerative stenosis, radiographic findings had little help for surgical indications. Future high-quality studies may change these recommendations. So now we're getting a little nerdy and talking about the mechanism of injury. Now, one thing I want you to make sure that you don't take away is that you think of this as some sort of like degenerative process that's wearing out your spine. This is more of an age-related spine, and the main factor is probably genetics. It's just to conceptually understand what's causing your pain. So initially, there's changes to your disc, which causes a reduce in disc height, which puts excessive stress on the facet joints or the posterior structure of your spine. Now, this excessive stress or load causes the enlargement of those bones and capsules, which can put pressure on the nerve. Subsequently, this causes further reduced height and instability, which causes creases in your ligament of flavum, which is one of the ligaments that goes along your spine between the spine and the spinal cord. This can increase pressure on the spina dura and then can cause structural instability over long periods of time. This further propagates existing hypertrophic changes, and then this causes decreased arterial flow, which is ischemia, and then venous congestion. And these are the two things that drive the pain and the symptom of this condition. Thank you so much for watching our video on lumbar stenosis. We hope this gives you some clarification of the condition and which treatment option is best for you. If you did find the video beneficial, please like the video and subscribe to our channel.